We can go ahead and go on to the next slide. Again, those who are just jumping into the room, we hope you're settling in and ready to share the next 90 minutes with us as we dive into some great HIPAA and FERPA content. Before we officially get started, I do want to share a few webinar logistics. You can find the audio settings on the left side of your dashboard. We do want to remind everyone that all participant audio lines are muted. And we encourage you to use the chat box to communicate with the host and panelists today if you have any technical issues or questions that come up. We also have the Q&A box enabled so that you can submit any questions that you may have related to the content. We are recording the learning session today, and we will be sending out the recording and the slide deck to you within a week. And you are very welcome to share these materials with any of your colleagues who may not have been able to make it today. We also will be sending out certificates of attendance within a week, and those will go to those who attend at least half of the session today. The learning session is brought to you by the Center of Excellence for Protected Health Information, otherwise known as CoE-PHI. The CoE-PHI develops and disseminates resources, training, and TA to improve understanding and application of health privacy laws and regulations. We do want you to note that the resources, training, and technical assistance and any other information that's provided through the CoE-PHI does not constitute legal advice. The session today is also brought to you by the Mental Health Technology Transfer Center Network, also known as MHTTC. Our network supports resource development and dissemination, training and technical assistance, and workforce development for the mental health field. And if you have not visited our websites previously, we encourage you to do so. I'll drop the links into the chat box right now so that you can check out our websites outside of this session. Great. We can go on to the next slide, which is really just to say that the CoE-PHI and the MHTTC network projects are both funded by SAMHSA of the U.S. Department of Health and Human Services. And so the opinions that are expressed here today are the views of the presenters and do not reflect the official position of HHS or SAMHSA, but we're really thankful for the funding that we receive from SAMHSA to bring trainings like the one today to you, free of cost. So again, welcome, and to those who are just signing on, thank you for joining us. In our session today, we will be sharing content that focuses on federal regulations, not state-specific regulations. And we aim to describe how federal health privacy laws, such as HIPAA and FERPA, apply to student mental health information. And we will also explain how student mental health information can be protected and shared in compliance with these federal health privacy laws. We'll also have some time to walk through a couple of common scenarios involving student mental health information, scenarios that arise in school settings. And we'll do this through some case study discussions that will be led by some clinical and legal experts that we have present with us today. And then we'll close our session by sharing some relevant resources with you and also sharing how you can obtain technical assistance through the CoE-PHI. So with that, I'm very excited to introduce our presenters and really the content experts for today. We have Abigail English joining us. Abigail is a lawyer, researcher, and advocate for the rights of vulnerable young people. She provides consultation services to nonprofit organizations and public agencies on legal and policy issues in adolescent and young adult health, including federal and state health privacy laws. She's currently a consultant for the National Center for Youth Law and for the Center of Excellence for Protected Health Information, and also an associate professor at the Gilling School of Global Public Health at UNC Chapel Hill. We also have Katie Stinchfield with us, who is a private practice school mental health consultant and clinical supervisor working in rural community mental health in Oregon. She is also the past director of behavioral health programs at the National School-Based Health Alliance, where she led the School-Based Health Alliance's mental health and substance abuse prevention initiatives for schools and school-based health centers. Katie has worked with children and families in mental health, education, and social services fields for over 20 years, and is both a licensed professional counselor and a licensed school counselor in Oregon. And last but not least, we have Dr. Steve North with us. Dr. North is a practicing rural family physician with additional certification in adolescent medicine and addiction medicine. He's currently the Vice President of Medical Operations for Eleanor Health, a technology-enabled outpatient substance use disorder program that's grounded in harm reduction and focused on the whole person. He's also serving as the medical director and is the founder of Healthy School, school-based telemedicine program. Thank you so much, Abigail, Katie, and Steve, for being here with us today. And without further ado, I'm going to go ahead and pass it over to Steve. Thank you for being here, Steve.
Jessica, thanks for that. I think that we're all gathered here today because the mental health of kids is incredibly important to all of us. And as a dad, as a member of our community, it strikes me every day how adolescent mental health is an evolving challenge. Instead of me talking, though, I wanted to start out and ask a poll. And we're going to do a word cloud with close to 1,000 people, which I've never done before. But thinking about your experiences, what is it that's keeping you up at night in relation to child and adolescent health privacy? Scan the QR code and type your answers. We'll take a look at those in about 30 seconds. If you forgot your cell phone, you can also check in the chat, and there's a link to the word cloud activity there as well. All right, let's jump ahead and see what our cloud is starting to look like. Can we go to the next slide? All right, so things that keep you up at night. Big words. Oh, they were there. All right, and we see safety being really high up on the list, and big bold words, and parents and schools and confidentiality keeps us up, absolutely. But the social aspects are coming through as well, and communication. And I see in here also sharing, and that the laws aren't clear. And all of those things are absolutely true, and are a challenge for those of us who work in this area on a daily basis. Please jump forward to the next slide. And when we think about school mental health, these are statistics from the 2023 CDC's Youth Risk Behavior Survey, which looks at tens of thousands of high school students across the country. And it found that 4 in 10 high school students experienced persistent feelings of sadness or loneliness in the prior year. Not just fleeting moments, but persistent, meaning lasting 30 days or more. 2 in 10 high school students in 2023 seriously considered attempting suicide, and 1 in 10 attempted suicide. These numbers are much higher than they were before the pandemic. There's been a slight downturn as we have moved back into schools, but we're nowhere close to pre-pandemic levels. And next slide, please. When the Department of Education, through their National Center for Education Statistics, took a look in 2024, early 2024, at school mental health statistics, they found that only 48% of schools found that they could effectively provide mental health services to all students who need them. The next 3 I find very interesting. 43% of school leaders said that they were moderately or extremely concerned about their students' mental health, and 41% had the same concerns about their staff and faculty's health. And finally, 27% were extremely concerned or moderately concerned about their own health. And this sets the stage for this conversation that mental health is something we need to be talking about and addressing more in schools. But we need to have a clear understanding of the legal framework of protections for students, providers, parents, and teachers. And next slide. We also, in the same survey from the National Center for Educational Statistics, they found that 3/4 of school had school counselors. Oh no, in school, sorry, in the schools that provide mental health services. 3/4 had school counselors. 67% had had mental health professionals that were employed by the school system, and 57% were partnering with outside programs. And 17% actually asked their school nurses to take on some of the mental health responsibilities. But at least in the schools where our school-based telehealth program is, rarely do the services have the capacity to meet the needs that are there. And now I'd like to turn it over to Abigail English, to talk about the laws and what they say and how they guide the practice of school-based mental health. Thank you.
Thank you so much, Steve, for that incredibly helpful introduction. Very concerning, of course. And I'm thrilled to be here today and want to thank all of the participants, more than 1,000 participants who have joined us live, to talk a little bit about what the laws say about how we handle students' health information and particularly their mental health information. Next slide. Before I start talking about the laws specifically, I want to give you a little bit of an overview. I'm going to talk first about the importance of confidentiality and information sharing. We saw both of those words popping up in the word cloud. Then I'm going to talk about which laws provide privacy protection and provide for information sharing, including primarily HIPAA and FERPA, with some reference to other federal laws and some general references to state laws. And then talk about what information is protected by privacy laws and whether behavioral health information, including mental health information, is treated differently, and how can protected information be shared appropriately within the framework that these federal and other laws provide. Next slide. Before I launch into this, I want to just mention that when folks registered for this webinar, hundreds, literally hundreds and hundreds of excellent questions were submitted in advance. Some of those questions were very general in nature. Others were very specific to particular states or locations or situations. The answers to some of the questions would depend on state law, but all of the questions that were asked helped shape the content of this webinar, and many of them will be used to inform future resources that will be developed by the CoE-PHI. So I'd just like to take this opportunity to thank everyone who submitted questions because they were extremely useful. Next slide. I'm going to take this opportunity again before I launch into the legal specifics to talk a little bit about the importance of confidentiality and information sharing and some basic principles related to both. Next slide. So why do we care about confidentiality protections? Why is confidentiality important? A basic premise is that it's useful to avoid negative health outcomes and to protect the health both of adolescents themselves and the public health. We know that protecting confidentiality encourages adolescents to seek the care that they need, and we have decades of research that have supported and affirmed the fact that privacy concerns do influence whether adolescents seek care at all, where they seek care, when they seek care, and whether they delay in seeking it. And once they seek care, how candid they are with their healthcare providers. So those are some of the really fundamental reasons why it's important to protect confidentiality. Next slide. I want to make some quick remarks about consent and confidentiality. I've put that phrase in quotes because so often the two words are mentioned together, consent and confidentiality, almost as if it were a single word. And they are very closely linked in clinical practice, in ethical guidelines, in professional organizations' policies, and in state and federal laws, but they are not the same. So consent for care is one issue, and it is, of course, a requirement before any kind of health care is provided. And confidentiality protection may go hand in hand with consent laws, but does not always go hand in hand. So confidentiality and disclosure provisions are found in a wide variety of laws, in the laws that allow minors to consent for care, sometimes also include consent and disclosure requirements, in general medical privacy and medical records laws, in the requirements of funding programs, and in insurance laws. It's also important to differentiate between consent to treat and consent to release information. The word consent is used so frequently in the healthcare and school arena that sometimes people are confused about whether we're talking about consent to treat or consent to release information. It's important to keep those two distinct. Yes, next slide. So it's also important to remember that confidentiality, while very strong protections are associated with it, is not absolute. And disclosures sometimes may be required even of information that is considered to be and is generally confidential. Some of the major exceptions to confidentiality are child abuse reporting. Every state has a child abuse reporting law and requires that information be reported even though it would otherwise be considered confidential. And that reporting relates to physical abuse, sexual abuse, and emotional abuse. Another exception is situations in which patients are threatening harm to themselves or to others. And then there are a host of other kinds of disclosures that are required by law in specific situations, such as, for example, reporting of sexually transmitted and communicable disease information and other things of that nature. Next slide. So some basic questions that I think are important to ask whenever one is confronted with a situation that involves confidential information. And those three questions are: what may not be disclosed, or what may not be disclosed unless some other criteria are met? What may be disclosed, or what may be disclosed as long as certain other criteria are met, and what must be disclosed if a certain situation is in place. So for the latter, what must be disclosed includes child abuse reporting information. And we're going to talk a lot over the next few minutes about things that fall into the categories of what may not be disclosed or what may be disclosed with a healthcare provider or health professional's discretion. Next slide. So not only is confidentiality protection important, but sharing information is important. And it's important for a wide variety of reasons. And one of the primary reasons, of course, is to support individual adolescents' health and well-being. And sharing of information is necessary and appropriate and important for making referrals. It's important for providing appropriate treatment. It's also necessary for billing and submission of health insurance claims. And then more broadly, sharing certain kinds of information is important for population health, for conducting research and developing targeted interventions, and for carrying out program evaluation. Next slide. So often, and I'm sure you all have heard this, and I have certainly heard it many, many times, I can't share that information because of HIPAA. I can't share that information because of some other privacy law. FERPA won't let me share that information. I'm here to remind us all that privacy laws don't absolutely prevent sharing of information. And that's where we need to think carefully and repeatedly and consistently about the power of a release. Most information can be shared as long as there is a legally compliant release of information, sometimes referred to as an ROI. And in understanding what is required for a legally compliant release, or in order for information to be shared appropriately, it's important to understand HIPAA and FERPA and other laws and state laws. It's important to keep in mind policies, protocols, and contracts. It's important to keep in mind ethical standards and also the sensitivity of the information. Today, for the next few minutes, we're going to focus primarily on HIPAA and FERPA. So let's go to the next slide. I'm going to say something right now that I will probably repeat 2 or 3 more times over the next little while. And that is a basic rule related to HIPAA and FERPA that it's extremely important to understand and have as a grounding for the other issues we'll be considering. HIPAA protects patients' information that falls within the definition of protected health information, often referred to as PHI. The HIPAA privacy rule definition of PHI excludes information that is part of a student's education record. So we ask the question, is an adolescent's health information part of their education record? If it is, it's covered by FERPA. And it is not covered by HIPAA. If it is not part of the education record, does it fall within the HIPAA privacy rule definition of protected health information? And if so, does it meet the other criteria for HIPAA privacy rule protection? And if it doesn't fall within that definition, is it protected by other state or federal laws? So you can see just from this one slide that there are a lot of complicated factors that we have to keep in mind. And so I'm going to try to sort of explain and walk us through some of those factors so we can get some clarity about these issues. Next slide. So now I'm going to dive into the HIPAA privacy rule and talk about that for the next few minutes. Who is required to comply with the HIPAA privacy rule? The rule says covered entities. It's a kind of a formal phrase, and it refers to 3 categories: health plans, like health insurance plans, healthcare clearinghouses, and healthcare providers, who are the really relevant factor for our conversation today. But it's not all healthcare providers. It's healthcare providers who conduct certain transactions, particularly billing and other communications electronically. The HIPAA privacy rule also applies to the business associates of covered entities and some of their subcontractors. What this means ultimately is that most healthcare professionals and sites who are caring for adolescents do qualify as covered entities or as their business associates, but not necessarily all health professionals who are working in schools. Next slide. So what information is covered by the HIPAA privacy rule? I already said that it covers what is defined as protected health information, or PHI. And that's health information that is individually identifiable, that is created or received by a covered entity, and it includes both written and oral communications, not just written communications. And when I say written communications, I am including both paper records, and anything that is contained in electronic health records. As I said previously, education records are covered by FERPA, not HIPAA, and they are excluded from the definition of protected health information in the HIPAA privacy rule. Next slide. So what about mental health information? As Steve introduced us, mental health is really a central focus of our concern today and will be the central focus of the case scenarios we discussed later. So is mental health information treated differently or the same under HIPAA? Well, generally it is not treated differently, but there is one specific protection, and that is the special protections that exist for psychotherapy notes. With few exceptions, the privacy rule, the HIPAA privacy rule, requires patient authorization prior to a disclosure of psychotherapy notes for any reason. And we'll see what that for any reason means in just a minute. So let's go to the next slide. This is a very dense slide. It contains the definition, and it's in quotes, of what is a psychotherapy note for the purposes of the HIPAA privacy rule. And I'll just call out the fact, I'm not going to read the whole definition, that it is the notes of a provider, and it focuses on the content, documenting or analyzing the contents of a conversation. It could be group, it could be joint, it could be individual, but it has to be a private counseling session. And those notes have to be kept separate from the rest of the individual's medical record. It does not include things like prescriptions, start and stop times, the results of clinical tests, and any specific summaries of things like diagnosis, treatment plans, symptoms, etc. So it's very specific protection, but a very important one for a mental health professional to be able to keep some private notes that are not more generally available. And we'll talk about what more generally available might mean in just a moment. Next slide. So what does HIPAA say about the confidentiality and release of protected health information? First of all, providers must protect the confidentiality of that information, and that generally means that they must have a signed authorization in order to share that information. That authorization is sometimes referred to as a release or an ROI. However, and there are always howevers in the law, there are some exceptions in HIPAA that either allow or require disclosure of PHI, protected health information, absent a signed release. And we're going to talk about those now. Next slide. So when does HIPAA either allow or require disclosure without the authorization of a patient or the patient's representative? It's allowed, but not required without authorization for treatment, for payment, and for healthcare operations. So when you go to the doctor and you need certain kinds of treatment, they can share that information with other healthcare professionals for purposes of your treatment, even without your authorization. However, generally, healthcare providers do obtain authorization to disclose PHI for these purposes, for treatment, for payment, and so on. Disclosure is also allowed, but not required, to avert serious and imminent threats, and in some circumstances for research, particularly if it's de-identified information. Disclosure is required even without authorization for situations involving child abuse reporting or court orders, and disclosure must be given at the request of a patient or the patient's representative. In the case of minor adolescents, that's usually a parent or guardian. We'll talk about that again, a little bit more detail in just a moment. Next slide. So to comply with HIPAA in the circumstances when an authorization is required, the authorization must include a variety of specific elements, and those are listed here on the slide. The expiration date or the event, generally compound documents, in other words, documents that are for a variety of purposes are not supposed to be combined in a single document. The information that is to be disclosed, the purpose of the release, and a signature of somebody who is authorized to provide that signature, and then other required notices. So that leads us to the question of who signs the authorization to release. But before we go to the next slide, I want to remind us all that we always need to consider whether state law requires additional elements or notices in a release of information or authorization. So now let's go to the next slide. Under HIPAA, who signs a release? First of all, adults, anyone age 18 or older, and emancipated minors, that's minors who have been legally emancipated in their state, sign for themselves unless they're under some kind of guardianship or conservatorship that limits their rights. Unemancipated minors must sign if they are considered the individual under HIPAA, and that's a technical term under the HIPAA privacy rule that I'll explain in just a moment. Normally, a parent, a legal guardian, or the patient's personal representative signs if the minor is not authorized to sign on their own behalf. So let's go to the next slide and begin to understand when a minor is considered an individual under the HIPAA privacy rule who has rights of their own. And minors are treated as individuals under the rule in 3 specific circumstances. They have the right to consent, and they have consented. They may obtain care without parental consent, and the minor or a court or someone else has consented, or parents have agreed that the care can be confidential, have acceded to a confidentiality agreement between a minor and a healthcare provider. And I've mentioned here again, as I did previously, state law matters, and state law particularly matters because it's state law that generally defines when minors have the right to consent to their own healthcare. Next slide. So ordinarily, parents are the authorized representatives of their minor child and have access to their protected health information under the HIPAA privacy rule. However, when the minor is, quote, the individual, as we just discussed in the previous slide, the parent is not necessarily the authorized representative of the minor. The minor can ask that the parent be their authorized representative, and often do. And parents' access in these situations are determined by a sort of a four-part test. If state or other law requires disclosure to the parents, the provider must disclose the information. If it prohibits disclosure to the parents or prohibits it without the permission of the minor, the provider may not disclose it. If state or other law permits it, then the provider has discretion. And if state or other law is silent or unclear, again, the provider has discretion to grant or withhold access to the information for parents. So this means that the HIPAA privacy rule really defers to other applicable laws, state or federal laws, and those could include state minor consent and confidentiality laws, the Title X family planning rules, the Part 2 substance use disorder rules, and other federal confidentiality laws. So again, one always has to consider the HIPAA privacy rule in relation to these other laws. Next slide. So the final point that I'd like to make about the HIPAA privacy rule is that there are very specific circumstances under which healthcare providers are granted discretion by the rule not to grant access to a minor's health information. The first one is that a parent, and I'm using the term parent really to encompass parent, guardian, other person with authority. Parent is not the personal representative if the minor is the subject of domestic violence, abuse, neglect, or endangerment, and other criteria in the rule are met. And the parent's access to the minor's health information may also be limited if the healthcare professional determines that giving the access would cause substantial harm to the minor or another individual. I'd like to wrap up what I have to say about the HIPAA privacy rule as a sort of transition to FERPA, and that is that I've focused a lot in these comments about the circumstances under which authorization to release information is required and access to information may be denied. But I think it's really important to remember that while confidentiality protection is extremely important and may influence when, where, and whether minors seek care, adolescents seek care, students seek care, we need to remember that usually adolescents, their parents, their teachers, their mental health professionals are all really on the same page and wanting the same thing, which is the health and well-being of the young person. So that's an important point to keep in mind, both in the implementation of the HIPAA privacy rule and in the implementation of FERPA. So let's go to the next slide. So for those of you who work in a school setting, FERPA may be more familiar to you than the HIPAA privacy rule, or the same, or for those of you who don't work as much in the school setting but have some contact, you may be a little less clear about FERPA. So let's go to the next slide. FERPA refers to the Federal Family Educational Rights and Privacy Act. It protects the privacy of education records that contain personally identifiable information, and it assures access to records by parents and guardians and by eligible students who are age 18 or older. Next slide. So who's required to comply with FERPA? Educational institutions and agencies that are receiving federal education funds. Sorry. Thought I had turned off all phones. Educational institutions and agencies that are receiving federal education funds are required to comply with FERPA. And if the agency receives federal funds and provides educational services or instructions to students, or the agency is authorized to direct and control students, they are considered subject to FERPA. School officials are subject to FERPA, and that includes some consultants, contractors, and volunteers. Organizations that contract with or consult with an educational agency or person acting for such agency, if they can be considered a school official, are required to comply with FERPA. Next slide. So what does FERPA protect? FERPA protects education records, and education records include records, files, and other documents which contain information directly related to a student and are maintained by an educational agency or institution, or by a person acting for such agency or institution who is considered a school official. Education records do not include oral communications. This is different from HIPAA, which does cover oral communications. And education records do include records maintained by a school nurse, which they also include IEPs and other special education records maintained by the school, and immunization records in the school's files. Next slide. What is not covered by FERPA? This is important. As I just said, education records do not include oral communications, personal impressions. They do not include records of instructional, supervisory, and administrative personnel that are in the sole possession of the person who created the records and not accessible to any other person. And they're sort of referred to as sole possession records. They also do not include records on students who are adults, age 18 or older, that are made by a physician, psychologist, or other recognized professional and are used only in connection with the provision of medical treatment. Next slide. So what are the access rules under FERPA? Who has access to education records? Except in rare circumstances, parents and guardians must be allowed to review and inspect the records on their request. An eligible student, age 18 years or older, in other words, an adult student, must have access and be able to review and inspect their own records. Access to anyone other than a parent or guardian or an educational student is restricted absent consent, except in a few circumstances. And access may be granted with consent or with a signed release. Next slide, please. 5420245. Who signs a release to permit access to education records? A parent for students under the age of 18, a student if the student is age 18 or older, and who's considered a parent for this purpose? Parents include a natural parent, a guardian, or an individual acting as a parent in the absence of a parent or guardian. And it's important in this situation also to think about any definitions that may be included in local education policy. Next slide. So when does FERPA allow disclosure without a signed release? FERPA allows or requires, sometimes requires, disclosure of a student's personally identifiable information without a signed release by a parent or eligible student in several different circumstances. And examples of that include disclosure to school officials with legitimate educational interests, disclosure of directory information, disclosures in health or safety emergencies, and of course, child abuse reporting, which is mandated in every state, and disclosures subject to court orders or pursuant to court orders. Next slide. School-based health centers are important providers of health services and mental health services on site in many schools, linked to many school sites. And it's important for us to understand how some of these laws, particularly HIPAA and FERPA, apply to school-based health centers, particularly with respect to the health and mental health information that those school-based health centers obtain from students and maintain on students' behalf. So school-based health centers, are they subject to HIPAA or FERPA? That is a question that arises very frequently. Most school-based health centers have a sponsoring agency. It might be a federally qualified health center, a local hospital, or another health system or site. And those sponsoring agencies are usually covered entities, and thus the school-based health centers that they operate or sponsor are also usually covered entities. If a school-based health center is a covered entity, they do have to follow the HIPAA privacy rule with respect to any of the students' protected health information that they have. Reminder again, education records are excluded from the definition of protected health information under HIPAA. So if for some reason a school-based health center's records fall within the definition of education records under FERPA, the school-based health center must follow FERPA rather than HIPAA access and disclosure rules. Next slide. These are complicated issues, and the Department of Health and Human Services and the Federal Department of Education issued guidance in 2008 and updated that guidance in 2019 to help figure out when records are subject to FERPA or HIPAA. And that is very helpful. That guidance is very helpful in determining whether a school-based health center's records would be subject to FERPA or HIPAA. And it depends on the relationship between the school-based provider and the educational agency. It's a case-by-case assessment, and some of the relevant factors include funding, operational and administrative control, and the services and functions that are provided. Next slide. So I'm going to make some closing remarks about HIPAA, FERPA, and other laws. Next slide. There are a lot of similarities between HIPAA and FERPA. They both contain restrictions on access to records. They both require written authorization or consent for release of information. They both contain exceptions allowing disclosure without written authorization. And there are also a lot of differences. The parent access rules are different. The requirements for who must sign an authorization or consent for release of information are different. The opportunities for information exchange exist under both laws, but who may exchange the information and with whom without a written authorization is different under HIPAA and FERPA. Next slide. So I've listed here on the slide a long list of important federal laws that may have a bearing on the confidentiality of health information. I'm not going to read the list, but it goes well beyond HIPAA and FERPA. And one that I will mention because it's of particular importance these days is the 21st Century Cures Act and its information blocking rule, which applies to electronic health information and therefore to the information that's in electronic health records. And that becomes increasingly important as those rules are implemented. Next slide. In addition, I've mentioned that it's important to refer to state law when considering implementation of HIPAA and FERPA. And the relevant state laws include things like the minor consent laws, medical privacy laws, funding program requirements, professional licensing laws, and evidentiary privileges. So that's been a whirlwind tour of HIPAA, FERPA, and a few other issues under other state and federal laws. And we're now going to take a turn to the clinical scenarios and see what we can learn from case studies. Next slide. I neglected to say that in closing, which law applies is a case-by-case determination. If FERPA applies, HIPAA does not. State law can apply where neither HIPAA nor FERPA apply. HIPAA and state law can apply at the same time, but HIPAA usually defers to more protective state laws, and FERPA and state laws can apply at the same time. FERPA generally preempts, but where FERPA is permissive, one would follow the more protective law. So that's the sort of ultimate takeaway about which law applies. And the most important thing to remember is that it's a case-by-case determination, but healthcare sites, schools, and other entities can develop policies that can help guide those case-by-case determinations. Next slide. So now we're going to turn to what we can learn from some cases, and I'm going to turn it over to Katie Stinchfield, who is one of our clinical subject matter experts. Katie, take it away.
Thank you, Abigail. Let's move into some practical applications of all of this information. Next slide, please. So to set the stage, you are a therapist employed by a community mental health agency, and your regular work site is the nearby high school. You often work collaboratively with school staff and are well known in the school setting. Lately, both the school counselor and the school nurse have been expressing concerns about a 15-year-old sophomore student named Juanita, reporting that she is missing several days of school every week. Next slide. When she does come to school, she appears to have poor hygiene, seems generally withdrawn, and does not socialize with her usual friend group. The school counselor has tried to discuss these concerns with Juanita's parents, but they work long hours and have been dismissive when they do respond. The school counselor and school nurse have asked for your help in supporting Juanita. Keep in mind that in your state, minors can consent to outpatient mental health services at the age of 14. Next slide. So we'd like to give the audience an opportunity to participate in the decision-making for this case. So we'll launch a Zoom poll momentarily. But given what you know about this case, what would you do? A, stop Juanita in the hallway during the next passing time and ask if she is okay. B, wait for a day when she is present at school, then call Juanita to your office during her study hall. Talk with her privately to learn more about her and see if she'd like to enroll in mental health services. C, get Juanita's address from the school office and visit her at home to see if you can figure out what's wrong. Or D, call Juanita's parents and yell at them for not taking these concerns seriously. So we'll launch the poll and allow everyone to respond. A few more moments to select a response from the poll that should have popped up on your Zoom screen. Looks as though we've largely selected option B, which and a few other selections as well. So in this case, we believe that the best answer is option B for both clinical and privacy reasons. Juanita's symptoms don't indicate acute risk, therefore don't need an immediate response. Waiting till she's at school allows you to reach out to her in a more natural way during a non-academic period and meet with her in private to review options. Given that she's 15 years old, she's of age to consent to services on her own in her state, and therefore doesn't require parent or caregiver consent to enroll. Meeting with her one-on-one also allows her to learn more about the supports available to her and also empowers her as an adolescent beginning to manage her own healthcare needs, and thus hopefully promotes some investment in the process. Next slide. We know that each case is different and that sometimes the best way to protect student privacy can be unclear. So here are some important clinical and legal considerations to keep in mind as you process these different cases. I'll let everyone read through these and then we'll move on to another case study by Steve.
Thanks, Katie. So our second study takes a look at Oscar. He's a 14-year-old with anxiety who is being seen at the school-based health center for therapy, and he's taking an SSRI prescribed by his family doctor. He is seeing the therapist weekly, and the school-based health center keeps his medication, so he stops by every morning to receive it. Oscar has been struggling academically, but over the past month has shown some improvement. The school guidance counselor is currently aware of Oscar's academic challenges and that he has been seen at the school-based health center, but does not know the extent of the care he receives. Oscar has not disclosed either being prescribed medication or being in therapy to his parents due to his perception of a stigma towards mental illness and therapy in their extended family and their church. Next slide. At the time of enrollment in the school-based health center, the parents did sign a release that allowed the school and school-based health center to discuss health issues, However, it does not differentiate mental health and physical health. His state Medicaid plan does not send explanations of benefits, and Medicaid does not require copay for the medication. Oscar's been struggling academically. Oh, we duplicated that. But last week, Oscar's parents approached the school guidance counselor with concerns about his academic performance. And so now we've got a poll to ask questions about, or some potential responses. So what can the school guidance counselor share with the parents? A, all of the health and information in the education record she knows because their relationship is covered by FERPA. B, nothing because Oscar has not given his therapist or his doctor permission to share information about his mental health treatment. C, only information in the education record covered by FERPA. Or D, only mental health records, excluding physical health records. So we'll open up the poll and let people take a look at that. All right, let's see some responses. So the correct answer to this is C, but we've got some feelings sort of all over the place on this one. And the first one, the first response that and I appreciate the comment that was made that really we should be using the phrase school counselor as opposed to guidance counselor, and I'll work to do that moving forward. Thank you. Did not mean to minimize the scope of what school counselors do. So the first response, all of the health information in the education record she knows because their relationship is covered by FERPA. That one is not correct because while she may know that Oscar's receiving mental health services, those mental health services are covered by HIPAA, and in his state, at age 14, he has the authority to consent to the release to his parents and other entities. The second answer, nothing, because Oscar has not given his therapist or his doctor permission to share information about his mental health treatment. No, she can share everything she knows about him having academic difficulty. And even though that is why he's seeking mental health therapy and care, that combination of anxiety impacting his performance at school, C is the correct answer because she is only authorized to share information in the record covered by FERPA. So let's talk through this a little bit more and jump on to the next slide. So when I sort of think about how to support a student like this, I go as a adolescent medicine specialist, I know that it's often best for students, for adolescents and their families to be involved in therapy together. And over time, that would be my goal for treatment, is to help reach that point. But at this point in time, Oscar does not want to share that information, and I need to respect that. So in evaluating the parents coming in this sort of scenario where the school counselor knows a little bit of information, I think that we can begin the conversation about his school performance and then see if they bring up the anxiety. But they cannot share what they know about any care that he's received. In regards to the laws, this is this interplay between FERPA and HIPAA clearly. Additionally, state laws apply that in his state, and it's one of many, at age 14, he can consent to outpatient mental health care. In many states, that includes receiving medication, But once an adolescent is admitted to a hospital or the desire is there for admission, parental consent is necessary. But outlining which states are which is outside of the scope of this. So this is just another area of situation to consider. And I think that hopefully we're providing a framework for how you can work through each of these situations and unique situations that you see at your schools. To talk more about sort of key points and wrap up, I'd like to turn this back over to Katie.
Thank you so much, Steve. So we're beginning to wrap up the presentation portion and we'll move to Q&A soon, but we wanted to touch on some key points before we do that. So on the clinical front, stepping back from all the details of this and all the nuances of interpreting these different laws, we just want to highlight that privacy regulations protect your students and help you to understand the boundaries and protecting and sharing information about students and families. So we're really looking out for their best interest. And when you're in doubt, you can review clinical considerations from the case studies we shared today, and the slides will all be provided to you. You can seek clinical supervision and consultation from your supervisor, or if your agency has a privacy officer or a legal advisor. And also review resources such as the School-Based Health Alliance's HIPAA, FERPA, and School Health Resource, different resources from the Center of Excellence related to PHI, and not only this webinar, but last year's webinar on this topic. And with that, I'll pass it to Abigail for legal considerations.
Thank you so much, Katie, and thank you both Katie and Steve for those really great scenarios. I think my sense is that they represent fairly common situations that arise in school and school-based health center settings these days. And so just hearing the two of you talk about some of the considerations and seeing what participants thought about the questions that were asked suggests to me that these issues really are on folks' minds, and that continuing to ask ourselves what the best ways are to provide really good support, really meaningful support to students while keeping in mind what the legal issues are is a critical priority for the school setting. Mental health issues are currently of critical and pressing importance in the schools for both students and professionals. I was very struck by the statistics that Steve included in the introduction, not only how much school administrators are concerned about their students' mental health, but how much they're concerned about their staff's mental health. So these are on a lot of people's minds for a lot of different important reasons. HIPAA and FERPA are two of the federal laws that provide both privacy protection and ways to share students' health information. Records that are covered by FERPA, as I've said several times now, are not covered by HIPAA. And other federal laws, such as the Part 2 Substance Use Disorder Regulations and the 21st Century Cures Act, are also important for proper handling of students' health information. And state laws are essential to consider when thinking about privacy protection and information sharing. And finally, a point that I made previously is that privacy laws do not prevent sharing if the right steps are followed. Next slide. We wanted to close with visiting some basic practice principles, and those are autonomy, transparency, and trust. Autonomy really refers to the ability of individuals and their families to make independent decisions about what happens to their bodies, to their information, and to act independently. It's a very important principle in the delivery of health services and of mental health services. It's an important ethical principle, and it's an important foundation of many of the privacy laws that exist in this country. Transparency is also a critical component of implementation of legal principles and legal requirements. So, for example, if you have a young person whose information is going to be shared with other health professionals, with school officials, or with their parents or family members, then it's important that the young person understand that that is going to happen. It's important that families understand what information they have access to and when they might not have access to information and why. That kind of transparency is really fundamental to the trust that has to be established in order for good services, good, appropriate, meaningful, supportive services to be provided that can really enable young people and their families to be candid with health professionals, with school staff and supportive professionals about their needs, about their behaviors, about what they are doing, what they need to do, what they can do. And that trust is fundamental to successfully providing services to young people. So I'm very appreciative that the CoE-PHI and MHTTC has provided this opportunity for us to look at some federal laws, to look at some relationships between federal laws and state laws, and then to think about how those federal and state laws might have a bearing on the delivery of appropriate mental health and other health services to students like Juanita and Oscar, whom Katie and Steve talked about in the case scenarios. So thank you, and I'll turn this over now to Michael, who's going to handle some question and answers.
Excellent. Thank you so much, Abigail, and thanks to our entire terrific presenter team today. Hello, everyone. My name is Michael, and I'm part of the CoE-PHI team. It's really great to be here with all of you today. Thank you for attending. So, given the very large number of participants on today's webinar with us and the time that we have allotted, we unfortunately won't get to address all audience questions. As we previously mentioned, hundreds of interesting questions were submitted in advance of today's webinar by those of you who registered. All of your questions help to shape the content of this webinar and will also be used to inform future resources developed by the CoE-PHI. Prior to today, our team reviewed the questions within the registration for common themes. And what we plan to do now first is address those common themes of questions that we identified. So I'm going to be asking Abigail a few questions now, as time allows, that are representative of those common themes. Again, we thank you all for your helpful questions. So, Abigail, the first question is, are mental health professionals who work on site in schools required to comply with HIPAA or FERPA? Abigail, I think you're muted.
Thank you, Michael. I'm so sorry that I was muted. I really appreciate your helping to cull through the hundreds of questions that we received from the participants, and look forward to working with CoE-PHI to develop answers to a wide variety of those questions. But in terms of whether mental health professionals who work on site in schools are required to comply with HIPAA or FERPA, mental health professionals may be required to comply either with HIPAA or with FERPA. It depends on who employs them and the nature of their records. If the mental health professional is working for a covered entity that is subject to HIPAA, or is an individual mental health professional who is considered a covered entity, then their records, including electronic health records and oral communications, would be covered by HIPAA with respect to confidentiality protections. And if the mental health professional is working in an educational institution or agency, or if they are considered a school official and their information becomes part of a student's education record, then the handling of that information is subject to FERPA's access and disclosure requirements.
Thank you so much, Abigail, for that helpful answer to this question that appeared several times throughout our registration. The next question, Abigail, is what is the impact of state laws on confidentiality protection and information sharing under HIPAA and FERPA?
Thanks, Michael. That's another really good question that comes up frequently. There are several ways that state privacy laws may have an impact on confidentiality protection and information sharing under HIPAA and FERPA. First, it's always important to be aware of relevant state laws. State law may apply where neither HIPAA nor FERPA applies. Also, if state laws are more protective, they may control. HIPAA usually defers to more protective state laws. On some issues, FERPA controls and takes precedence, but where FERPA is permissive, a more protective state law should be followed. Second, under the HIPAA privacy rule, state law will be very important in determining whether an unemancipated minor is considered to be an individual with their own rights under the rule. If a minor is authorized to consent for their own care and does consent, then they are considered to be the individual with specific rights. One of those rights is to sign an authorization for release of their own protected health information.
So much, Abigail. The theme of the impact of state laws came across very commonly throughout the registration question, so thank you for addressing that. And the third question, Abigail, is which laws apply to information about a student's substance use? HIPAA, FERPA, or something else?
So thanks, Michael. That's a question that, we would love to have had another hour or two to address in the substance of the webinar, but today's webinar was focused more specifically on mental health issues, although legal and clinical issues related to student substance use are also of critical importance. Whether information about a student's substance use would be subject to HIPAA, FERPA, or some other federal or state law would depend on who delivers the services, where they are delivered, the nature of the information, and where the information is held. So, for example, if the information is protected health information that relates to services provided by a covered entity, it would be subject to HIPAA. If the information relates to services provided by a school official and is part of a student's education record, it would be subject to FERPA, not HIPAA. If the provider of substance use disorder services meets specific criteria as a federally assisted program, they may be subject to the federal Part 2 substance use disorder confidentiality rules. And if the information is contained in a student's electronic health record, it may also be subject to the 21st Century Cures Act requirements for sharing electronic health information. And finally, as I've repeatedly said today, specific state laws related to substance abuse may also apply. So I really appreciate these three questions that you've asked, Michael, and I'm wondering if you have any questions or if we have time for any questions that Steve or Katie might be able to respond to.
Thanks, Abigail. That was a really helpful response. We really appreciate it. We do have a few more minutes for questions before we go to our closing. I do see one within the chat. I think we'll be able to answer for folks, which is how are you defining healthcare providers in this? Would this include school counselors, social workers employed by the school, or will that be covered later during the presentation?
So Michael, are you addressing that question to me?
So, I'm not sure who it should be addressed to, but, if you're able to answer it, or Dr. North, Katie. Otherwise we could follow up, with a technical assistance call for this person who answered this, who asked this question.
I'll just give a very quick answer. The question of provider from a legal perspective depends on definitions that are found in the laws. So HIPAA has definitions of who is considered a covered entity and what types of healthcare providers are covered by the HIPAA privacy rule. And it's a fairly complicated definition that involves who submits certain kinds of, or engages in certain kinds of transactions electronically. However, I think there are also, the term provider doesn't only depend on what the law's definitions are, but is a term that is used in clinical context. And I'd like to defer to either Katie or Steve or both if they have any comments about, you know, sort of what they have in mind when they talk about providers.
I'll let Steve go first. I see he unmuted.
Oh, gee, thanks, Katie. I appreciate that. So when I think about healthcare provider, I think about who is the employer and what is their licensure, and sort of where they sit. Are they within the school-based health center? Are they at an outside covered entity such as a private practice or a federally qualified health center? Those are all HIPAA protected. The school nurse, another healthcare provider, clearly, however, is employed by the school district and is therefore is covered by FERPA, and the records are covered by FERPA. The school counselors, who are LCSWs, LPCs, or other designations, so therapists working and employed by the school system or school counselors, that is entirely FERPA covered, and in my interpretation, and I'm open to correction from Katie or Abigail about that.
I agree with Steve. I think that the employer matters a lot. And so even if I'm a licensed professional counselor, if I'm employed by a school district, then I believe those records fall under FERPA. Again, I'll defer to Abigail to correct me, but I believe that's the answer.
I'll just close by this. I really appreciate both Steve and Katie's comments. And I think that, you know, who a particular professional is employed by is very important, but I'd just like to emphasize that these are case-by-case determinations. And so in any given situation, you need to think about, you know, what your school district requirements are, what your policies are of the school district, in addition to what does FERPA say, what does HIPAA say, what does state law say, what are certain contractual arrangements between the school district and whoever is offering the services. So these are all the kinds of criteria that need to be considered. And the joint guidance that was referred to earlier during the presentation and was linked in the slide to the joint guidance of the Department of Education and the Department of Health and Human Services can be very helpful in working through these case-by-case determinations.
I've seen a few theme questions popping up that I thought I would try to briefly address. When working in a school, there are some other layers, I believe. So if you are a mental health provider working in schools, there are obviously, you know, HIPAA protections, FERPA protections. There are the privacy practices of the organization you work for, which may be more stringent than those federal or state laws. And so observing those limitations or boundaries is important too. So deferring to your employer. And then I think also the ethics of your profession. I saw some comments about, is it okay to share this if I'm, this type of licensure in the school setting? And I think school staff and colleagues in the school setting can share whatever they would like with you. But then in terms of what you would share, I think it's important to be careful about what is ethically appropriate as well. So even though it might be okay to share under HIPAA or okay to share under FERPA, even if you have a release in place, I think from the mental health perspective, you want to be thoughtful about what's necessary to share and be cautious about protecting student confidentiality and only sharing what's absolutely necessary. So I think there's an ethical implication there as well. I'll let Steve and Abigail weigh in.
Katie, I agree with the ethical implications of what you're sharing, and thinking about the long-term consequences on the adolescent, that you always want to keep the sort of this being patient-centered, and even the conversation you may be having in the hallway that is off the record and all of those things that can have some negative consequence. And that's one of the great values of school-based health centers is students don't need to say why they're going to be seen there. It could be for the cold, it could be for their allergies, or it could be because they have privacy and confidentiality of the adolescent is, I think, from a healthcare provider standpoint, the most important thing that we do. Abigail, do you have more to add?
I think those comments, Katie and Steve, were really, really important and really, really helpful. And it just brings me back to those 3 best practice principles that I mentioned of autonomy and transparency and trust, and protecting students' confidentiality is one way of building trust. Being transparent about when and why you're sharing information, if it's necessary for you to do so, is another way of building trust. And all of those honor the autonomy of the student and of their families. Thank you.
Thanks, Abigail. I think we have time for one more question before we move on to our closing, and it is about verbal disclosures. And the question is, are you saying that FERPA would allow a social worker in a school to share anything that a student tells them orally? Is this information not protected?
I feel that's where professional judgment comes into play. And what's the benefit of sharing that? Because you're right, FERPA does not protect oral communication. So it becomes a, why am I being asked to share this information?
And also it requires being clear about whether that individual provider for some reason is covered by HIPAA rather than FERPA. Because if they're covered by HIPAA, then oral communications are covered. If they're covered by FERPA, oral communications are not covered. What that means is a couple of different things. Well, it means a lot of different things, but a couple of the things that it means are that parents and eligible students don't automatically have access to that information, which is what FERPA grants to information that's in education records. And it also means that an authorization under FERPA is not required to release the information, but an authorization may be required under HIPAA if HIPAA applies. It may be required under a state law if there's a relevant state law. So again, there are always a number of considerations that have to be taken into account.
I agree. And I try to ask myself, what purpose does this serve and how does it benefit the student to share this information? And it can be really difficult in the school setting. I want to sort of lift that up, that your colleagues and peers at work are often coming to you with intense concerns and a lot of worry and big feelings around what's going on with students, and really curious and wanting to know. And I think really setting those boundaries early and directly and being clear about what you can and can't share, and gently, honoring their feelings and their dedication to those students, but also keeping clear lines around what you can share about students and what's not available to share, in the interest too of maintaining student investment in you as a provider. If you're sharing their information, they very quickly are not interested in working with you anymore. And I did want to quickly say thanks to Fran in the chat for pointing out that community employed mental health providers who provide clinical services in schools, but not as part of an SVHC, would have liked to cover that more. That's the work I do, Fran. I totally hear you. And I think that quite often, because they're employed by those community mental health providers or community agencies, then those folks do fall under HIPAA. But happy to have a longer discussion offline. I know there's a lot of questions we're not getting to today. So back to Michael.
Thank you so much, Katie, and thank you, Abigail and Steve as well. Okay, thank you again to all of you who sent us your questions prior to today's webinar, and a very big thank you to Abigail, Katie, and Dr. North, our really terrific presenters today. So as we previously mentioned, just before we close, we just wanted to speak to you about the evaluation for today's webinar and how to access the Center of Excellence for Protected Health information. So please visit us at CoE-PHI.org, where you can browse through our extensive searchable resource library and our on-demand learning opportunities and directly request individualized technical assistance. Also, please be sure to join our mailing list. We'll drop that link in the chat for you. This will allow you to be made aware of any upcoming learning opportunities that we'll be hosting and any new resources that we release. I'll also be sharing the slides from today's presentation with all of you who attended today, as well as a link to the archived video version of the presentation.